and I'm going to hand it over to her now. Thank you, Dawn.
Hey, welcome everybody. Tonight's SCAI Bifurcation Club webinar series is on left main bifurcation algorithm and DK crush. The agenda for tonight, I'll give a brief introduction on the current state of left main PCI, and that'll be followed by Dr. Rob giving his left main bifurcation algorithm summary. And then we have Dr. Valeria Para-Diaz, who recently published, one of the co-authors publishing a state-of-the-art algorithm for bifurcation left main, and she'll be taking us through some of the nuances of this new algorithm. This will be followed by two case presentations, the first one by Dr. Yanis Hastazidis, and the second by Dr. Xiaoyang Chen. And in between these cases, we'll be able to take questions. We do have a moderator, online moderator, Dr. Lisko, who's an interventional fellow at Emory. So he'll be fielding the questions and bringing them forward between and after the cases. I'd just like to acknowledge SCAI and the unrestricted grant that was received by Medtronic in support of this tonight's webinar. If you are participating in this webinar, you are eligible to receive 1 CME credit and 1 ABIM MOC credit. Here's the disclosures of the moderators and speakers tonight for your information. To receive your CME, you can either go through the Learning Center and find it under My Courses, or you'll receive an email following the course. So just as an introduction, left main PCI is certainly the most important bifurcation that we're treating as interventional cardiologists. Outside the US, there was uptake of left main intervention, over a decade ago. But you can see in the US and the UK that more recently, the temporal trends show increasing use of left main PCI. And I think that's due to many factors, including complexity of the patients that are presenting nowadays and high surgical risk. But the important thing to note is that we can do a good job with this lesion subset. And among the centers and operators that are performing left main PCI, we're seeing excellent in-hospital MACE, around 2%, 2 to 2.6%. And this data is back from 2016, 2017. And the trends have shown decreasing complications and improved outcomes over time. And part of this is due to the education of operators on optimal techniques to treat this complex lesion subset. And the webinar tonight is designed exactly for that, for those listening to become more, have more expertise when they're approaching this important lesion subset. So with that in mind, I will move over and give the field to Dr. Rob, who's going to start talking about the traditional algorithm for approaching a left main bifurcation intervention.
Thank you very much, Dawn. We like to have case presentation, but I think it's important to have brief snippets of things that people ought to know. And in 2016, Xiaoyang and other operators from Asia and also the Europeans and I decided to publish this algorithm, which I still think makes sense. So let's have this the first slide for me, please. Dawn, are you going to share or should I share?
Oh, can you share yours?
Okay, let's see.
There you are.
So I don't know. Okay, so this is what we published. I'll go through this very quickly. So the most important thing is the criteria for left main intervention. Remember, the side branch is the driver for the bifurcation PCI. For left main, the criteria is the stenosis angiographically should be equal to or greater than 70%, or IVUS OCT left main MLA, minimum lumen area, less than or equal to 6 millimeters square, or by FFR less than or equal to 0.80. For non-left main, the criteria is a little different. The angiographic side branch stenosis should be equal to or greater than 90%. Again, the FFR should be equal to or less than 0.80. Next, please. The important thing is to remember the Medina classification. It's important to design to tell you where the lesion location is. And it's important to also tell you that you have to classify them. So the way that works is that if there's any stenosis more than 50%, if it's in the main vessel, you give it a 1. If it's below the branch, you give it a 1. And side branch, you give it a 1. And if there are no lesions here, then it goes to a 0. Typical bifurcation is a 1, 1, 1, and on the other end, you can have isolated osteostenosis, which is 0, 0, 1, meaning there's no lesion in the main vessel or beyond the side branch, but a side branch. Now, Chen and his group have defined lesion complexity based on this side branch classification of stenosis, but they've also been inclusive of lesion length equal to or greater than 10 millimeter. And this has been used in many, many trials now. And the definition 2 study really validated this, and also validated that lesion complexity increased with moderate to severe calcification, multiple lesions, bifurcation angle less than 45 degrees, main vessel reference vessel diameter less than 2.5 millimeters, thrombus containing lesions, or main vessel lesion length equal to or greater than 25 millimeter. And also Dr. Chen has defined that complex bifurcation includes 1 major criteria or plus 2 minor criteria. And again, the definition 2 study validated that. Next, please. So we went to define this, and this algorithm was created that in simple versus complex left main bifurcation lesion, a simple lesion once again defined on this side of the screen, demonstrating a side branch lesion length less than 70% stenosis, and our lesion length less than 10 millimeter. That makes it simple. The complex lesion is a side branch lesion equal to or greater than 70%, and our lesion length greater than 10 millimeters. And again, definition criteria increase complexity. So lesion classification and approaches to left main PCI are all determined by the side branch. Next, please. So why is the 10 millimeter length important? Multiple studies have shown that more than or equal to 10 millimeter length of side branch lesion favors a 2-stent technique. All these studies, EBC2, DK-Crush5, DK-Crush2, BBK1, and other small studies have all favored that if your lesion length side branch is greater than 10 millimeter, favor the 2-stent strategy. Next, please. So this was the algorithm we created in 2017, again, defining simple versus complex. In the complex lesion, mostly initially an Asian approach, but now very much used throughout Europe and the Americas. You preferably go to 2-stent technique, preferably the DK-Crush, which was the consensus at that time. If it's a simple lesion, an easy side branch access, you do a provisional stenting, which occurs in the majority of the cases, or more than 75% of the cases. We generally use a 1-stent technique. If the side branch compromise or the FFR is equal to less than 0.80, or TV flow is less than 3, then you convert to a 2-stent technique, which would usually be a T-stenting, or T with minimal protrusion, or TAP, or culotte. Or if the side branch, side branch has an angle that is not favorable, maybe you should think about culotte technique. But provisional is the important way to go with simple lesions, and 2 stents for the complex lesion. So this is what we proposed, and this has been popular. Now, Valeria is going to talk to us in a minute about what they have done now a little differently to incorporate other aspects to define lesion complexity. Thank you.
Terrific. Well, while Valeria is getting her slides up, certainly understanding the complexity of the left main bifurcation, either through the definition algorithm or the simplified algorithm that you presented, is important, and we'll see what the update is now.
Thank you very much. It's a great pleasure to be here tonight. So I will walk you through an update of the suggested algorithm for left main bifurcation treatment, recently published by my working group. So randomized data and data from registry have provided solid basis for percutaneous coronary treatment of left main bifurcation disease. However, when it comes to uniform recommendations, there are none on optimal stenting in this setting. And we decided to focus particularly on escalation rate and angiographic intravascular imaging determinants for subsequent stent implantation. When we look at escalation rate from registry, we see that the reported rate is quite low, but there's probably some bias as patients who received a second stent because of impairment of circumflex is probably because all these patients were classified as a two-stents technique, so precluding any insights into scenarios for escalation and also on reliable escalation rate. But also when we look at escalation rate from randomized controlled trials, we see that the rate varies across all the study, probably reflecting some different operator choice, different selection criteria, but also different definition for suboptimal circumflex result. And you can see here that among all the study, randomized controlled trial and registry, the definition for suboptimal result for circumflex requiring per protocol, the implantation of a second stent is quite different, ranging from angiographic determinants, intravascular determinants, and physiological assessment. So we came up with a suggested indeed algorithm, and we suggest in our algorithm to look first of all at the baseline complexity of the bifurcation lesion before embarking into the procedure. So first of all, starting from angiographic determinants, look at the Medina classification, so lesion complexity, but also bifurcation angle. And also include in your assessment, so pre-procedural planning, intravascular imaging determinants, which can be predictors for side branch occlusion. So look at side branch disease, for example, lesion length longer than 10 millimeters, but also plaque morphology. So have a look at plaque burden and also calcium arc higher than 60 degrees. So taking into account both angiographic and intravascular imaging determinants, consider two-stent strategy. And after that, so talking about a stepwise layer approach, consider after crossover stenting, which are the angiographic imaging and physiological findings, which require an escalation to two stents. So based on angiography, have a look at side branch occlusion or impairment of TIMI flow, side branch dissection higher than B, or side branch severe ostial pinching. At intravascular imaging, side branch medial dissection or MLA lower than 4, and look at the functional assessment of side branch impairment by means of FFR or IFR. And based on the impairment of one or more, these findings consider to escalate two stents. And of course, a final assessment with intravascular imaging, because it provides information about expansion, apposition on the stents, and geometry of the bifurcation. Thank you.
Great. So you just added some levels of sophistication to the original algorithm, and certainly those are more things to consider, including the addition of imaging, which is nice to see. And now we'll move on to the first case, and then we can pause for a few questions. Okay, Giannis.
All right. So hello everybody. Let me see how this can be applied to a specific case. I'm going to focus on the tips and tricks and steps of left main bifurcation with a dedicated upfront two-stent technique with a TM protrusion approach. Brief history: a 74-year-old man with multiple risk factors, worsening stable angina, on optimal therapy, refractory, preserved EF, left main disease and middle AD by angiography, referred to bypass surgery. He declined surgery, and then the ball back to us. This is the baseline angiography. We talk about a true distal left main bifurcation with features that look like a complex left main bifurcation. According to what we just discussed earlier, very briefly, here we have a complex bifurcation, up-front to stand technique. The question is always, do we stand the side branch first or the main vessel? When we have fear that we might lose the side branch, it's better to start from the side branch, circumflex in particular here. And the best approach is, given that this is not a pure T bifurcation, clot could be a possibility, but we elected to go with inverted tap because we felt that the angulation is more favorable for tap. Decay crash, of course, is always a consideration. So I'm going to show you very briefly an animation of what we did, and then I'll show you what we actually did. That's animation is based on the white paper published by the EBC a couple of years back, and it's available in this link. So the inverted T and small protrusion, because inverted means that we start from the side branch first because we have fear of losing this. So we position the stand there according, always sized according to the side branch. Then we deploy the stand, always have some room in the proximal main vessel for an adequate pot at the end, at least 6-8 millimeters in the main vessel. Then what we do a nice pot with a short NC balloon in high atmospheres to open the struts to the main vessel nicely here. And then always the balloon marker at the carina. And then we rewire with a wire exchange technique or other approaches, or maybe a dual lumen catheter. We rewire from distal struts the main vessel. Then we do kissing. We can do sequential and then simultaneous, I'll show you. Then we deploy the main vessel stand, which, as you see here, has to protrude by a couple of millimeters, a couple of struts, a couple of crowns, essentially, into the main vessel. And always we keep an uninflated balloon into the side branch. We pull back the stem balloon and we optimize the ocean of the main vessel. And then we do the kissing balloon inflation with the stem balloon pulled back and then the uninflated balloon of the side branch, in both inflated in low atmospheres. And finally, pot, and keep in mind for tap, we don't need to go deep in locating the balloon because we have to respect the metallic neocarina. So the pot balloon should be always meant just to optimize the proximal main vessel and avoid the deep dilatation, which might distort the neocarina. And that's essentially from what we would expect to see. That's a patient-specific simulation of the tap technique, inverted tap technique. That's from the inside. You see the neocarina here nicely protruding by a couple of millimeters into the main vessel. Now, let me now show you what we did in this actual case. That's, as we said, a complex left main, distal left main bifurcation. We started with the circumflex pre-dilatation with a compliant balloon. This is the IVUS pullback from the LAD to the left main. LAD remains a designated main vessel, but we start from the side branch here because of the complexity of disease. You see here that as we pull back, there's some disease in the middle AD, which we fixed. And then here, proximal AD, fibro, calcific stenosis right here, the junction with the circumflex here. So we talk about complex fibrocalcific disease, no more than half a circle of calcium into the ostium of LAD. And then you get to see here the IVUS from the circumflex to the left main, right after the pre-dilatation. And as you see here, again, fibrocalcific plaque on this side, more than 180 degrees as we enter now with the other wire into the LAD. So what we do first, we start, as we said, with a stent to the circumflex, the side branch, designated side branch in that case. Of course, it's the side branch because it's circumflex, so it's a 3048 DS, long stent. We position this all the way to the ostium of the left main to have enough space for a good pot. And the technique is crossover, covering the ostium of LAD. You see here the stent inflation. Always the stent is sized to the distal main vessel. Then we do the first pot. Keep in mind that as shown here, the distal marker of the balloon should be at the carina, the left main carina. we go with a non-compliant balloon, 4O12. We always inflate in high pressures to oppose nicely the stent into the proximal main vessel, which in particular, this particular case is called left main. Then what we do is we exchange the wires. We take the LED wire and put it down into the circumflex, and then we pull back the jailed circumflex wire out into the aorta, and then again we rewire with a loop, preferably to secure that we're within the struts, within the stent. So with a loop, we rewire essentially down into the LED. That's a wire exchange technique. And then what we do kissing balloon, and there's a specific technique here. Lately, we like to have the sequential kiss and then the simultaneous. So what is sequential? We get two short in C balloons, 3O12, both sides to the distal main vessel, distal LED, and distal side branch, distal circumflex. And then we position both with their centers at the carina of the left main. And then we inflate first on high pressures the one balloon, and then the other balloon. And usually we prefer to inflate first the balloon with the stent. And then finally, we do the simultaneous kissing balloon, in which case we use exactly the same balloons, but now we inflate them both simultaneously in low pressures. In the sequential, we do high pressure inflations. In the simultaneous, we do low pressure just to restore the carina in the middle. So both inflate at 10 atmospheres and then deflate it simultaneously. This is essentially the technique, the tip and trick of a nice kissing balloon inflation, sequential and simultaneous. And then what's next? Time now for the main vessel stent with a small protrusion by a couple of millimeters, as shown here, into the left main, and then keep the uninflated balloon into the side branch, into the stented circumflex. As we deploy the stent, we then pull the stent balloon back into the left main, and we do another inflation to optimize better the ostium of the LED. And then finally, we inflate both balloons, the balloon that was stationed to the circumflex and the one that is the stent balloon into the LED on relatively low pressures at 10 atmospheres, just to make sure that we restore the metallic neocarina at the middle, and then we deflate simultaneously both balloons. We take them out, we do the final pot. Again, important not to have deep intubation of this balloon to avoid distorting the neocarina. Just keep it out into the proximal main vessel. Here, a little bit of the balloon is out into the aorta. It's a 4O, big, short, big in diameter NC balloon. Inflate this in high atmospheres to optimize the result. And then that's the final result angiographically here. Pretty decent. And this picture here without contrast. Good TIMI3 flow, well expanded and opposed stent angiographically, no dissection perforation, and the results were also confirmed by IVUS. That's the circumflex pulled back to the left main. Here you go. We have the stent to the circumflex. As we pull back, you're going to see the stent, the LED stent coming in right here, right here. That's the LED coming in, the left main, two wires, and then all the way, small protrusion to the aorta. And then finally, that's a pullback of the LED to the left main. We expect to see the metallic neocarina here as we pull back. That's still an LED, proximal LED. And you get to see here the neocarina coming. Here you go, exactly. So that's essentially the neocarina here. That's the metallic neocarina, the part of the LED stent that is protruding into the left main. And this part here is the circumflex stent. And they both come into the left main. And don't forget the rule of 8765, which is coming from East Asian data. Maybe in the Western societies, it's even bigger areas. And with that, I would like to thank you for your attention.
Terrific. Well, I think we can pause now and Dr. Lisko can bring some questions forward to the panel.
Thanks so much, Dr. Abbott. We have a lot of great questions in the webinar chat. So for everyone that's on, if you have any questions, feel free to post them there and then we can try and work through them over the course of the discussion. So up front, not a conversation that occurred much, but is there any consideration for mechanical support in these algorithms, and what's everyone's clinical practice? Are you basing it solely on EF, doing right heart caths, both?
Okay, any speakers want to?
I think that, for elective patients who are stable, who don't have LV dysfunction, and all these trials, and also in all the trials that Xiaoling did, people were not decompensated, they were they preserved EF for the most part, and also in the Excel trials. But I don't know, of course, if you have LV dysfunction or somebody in the middle of cardiogenic shock or bad ventures, it's important to check the EDP. If the EDP is elevated, I think should get mechanical support. And again, if you have very calcified left main bifurcation, use atherectomy of any kind, you should think of mechanical support. What do you think, Xiaoling or Yanis or Don? What are your thoughts?
Yeah, I totally agree. We talk about high risk PCI, in which case we have to consider mechanical support with impeller or whatever devices we have available. And high risk PCI means high risk complex patient and or high risk anatomy. For instance, in my case, you see that the anatomy is definitely complex. The patient has high risk features like low EF, so one wouldn't be wrong to consider upfront mechanical support.
Xiaoling, what do you think?
I fully agree. In my case lab, if the patient has the left ventricle ejection fraction less than 30%, definitely we will use mechanical support. Otherwise, if EF between 30 and 40%, so impeller or IBP will be standby. Thank you.
Valeria, and what about Holland? What are you doing there?
Absolutely agree. So first of all, consider the ejection fraction of the patient, and if it's impaired and the anatomy is complex, of course the use of a mechanical support device give you the freedom at the time to complete the procedure in the best way. So use of intravascular imaging, assess the procedure, pre-procedural planning, optimize the procedure. I think that's the main advantage.
I think certainly with LV dysfunction, if you're considering not using it, having a right heart cath and understanding the cardiac output is important. Another way with just the arterial pressure and the LV-EDP is to look at the coronary perfusion pressure. Certainly if that's greater than 60 and you don't anticipate prolonged ischemic time, you are probably fine without mechanical circulatory support device. But if you are not planning it up front, you must know your access site and options if it becomes necessary. You don't want to be figuring it out last minute.
And if you're going to upfront plan to perform atherectomy in a patient with a reduced EF or a borderline reduced EF, does your choice of atherectomy device bias you one way into support or not with either shockwave or rota?
For me, not particularly, because if there is severe calcification and there needs to be plaque modification, there's always a risk of ischemia and no reflow, even though it may be less with one device versus another. It's certainly not zero. And you have different causes of ischemia with the, IVL, the balloon needs to be inflated for a few seconds at a time. With rotational atherectomy, there's a higher risk of no reflow, but each device has its own pros and cons, and you have to use the best device for your situation by imaging, or a combination of devices in many cases.
This is actually a question from Dr. Chen, so I feel like it's certainly worth bringing up. How long is the duration of DAPT after left main 2-stent approaches?
Yeah.
So I would say that there's no clear evidence to answer this question, but the consensus and the experience at this point, without clear randomized data, is in favor of prolonged and strong DAPT, especially when we talk about 2 stents implanted in the left main.
So Yannis, would you drop aspirin at 1 year and just keep Plavix or something else indefinitely, or keep them both?
As I said, I believe in the absence of evidence, strong randomized data, the practice, the recommendation from EBC, if you want, is for strong DAPT and prolonged DAPT for more than a year, actually for many years, especially when we talk about 2 stents in the left main.
So what do you do in China, and what do you do in the Netherlands? Sorry, John, I need to ask different parts of the world what they're doing.
Yeah, usually we prescribe DAPT for 1 year for two-stent technique for left main. After that, we will stop aspirin and keep ticagrelor.
And Doc, when you say strong and prolonged DAPT, if you're going to send someone on clopidogrel, are you checking for responsiveness routinely in these cases?
Yeah, I was going to state we don't have any prospective data. And if you look at the complex, there have been studies trying to pull out the complex patients in the shorter DAPT studies. And certainly the complication rates and MACE are higher if you do, say, short DAPT like 3 months and drop either the P2Y12 or aspirin. So I think what is clear is you want to have that minimum of 12 months. We don't have data one versus the other. I like to preload all of these patients because I think that's the safest way. If you have complications, potentially things like perforations or complications that require, getting them off of the anticoagulant rapidly, they need to be pre-treated. So I pre-treat them. And if there's generally default to a more potent P2Y12, but if using Plavix, I would head check the genetics to make sure they're a responder. And in which case it may be adequate, but we don't have trial data to support that. But my own practice would be to preload them with a potent P2Y12 or to check for a response to Plavix, do a minimum of a year, preferred 3 years, and anybody not high bleeding risk. And if somebody is prohibitive bleeding risk after the 1 year, drop aspirin, continue potent P2Y12, which sounds like what Xiaoyang is recommending as well.
Thank you so much for that great discussion. A lot of the questions that are coming in are about DK crush and some tips and tricks regarding that technique. So maybe we could save those for later on in the chat.
Absolutely. So let's move on, and Xiaoyang will give us the step-by-step to DK crush.
So can you see my slides?
Yes.
Okay, thank you. Okay, once again, thank you. Thank you very much for inviting me to present a double kissing crush technique. I will introduce my case step by step. So patient is 74 years old. He have multiple risk factors: previous smoke, hypertension, renal failure, unstable angina for 3 months, left ventricular infection. Ejection fraction was 46%. So these are baseline angiography. So from left to right are epicaudal aisle cranial spider view. So all view shows very diffuse lesion in single flash. So we use 6 French guiding catheter from femoral artery. So from epicaudal, you can see very tight lesion as a proximal single flash. And also a very tight stenosis as a proximal ID. So from views, so we can calculate the possible diameter of left main should be around 4.5 to 5 millimeters. So immediately after predilation for distal symphysis lesion, we check the IVOS. So from 2 still images of IVOS, you can see as a middle body of left main, there is a very, very large lipido pore, so which indicates it's a unstable plaque in the left main. But when I was from symphysis to left main as a osteal symphysis, you can see a very critical stenosis and also very long crying length. So we go through decay quality technique to BMW wire in flex and LED. So from the spider view, can precisely calculate the lesion length. So finally, we use a long stem in flex. It's 3 by 28 millimeter SES, DS, and now 3.5 balloon in the LED. So keep the LED balloon in its position is very important because immediately after standing flex, we need to do first balloon quash. So on the right figure, you can see the stand in flex was fully expanded, but the middle segment of flex stand was not inflated perfectly. So immediately after standing flex, keep the balloon in the LED. So we use IWAS to check the stand inflation quality. This two images come from the Dr. Francisco Lavara, my great friend. He modified the key step for optimizing side stand. So it means if there is at least one side branch taken from the proximal flex, so the side branch stand size should be undersized for the very proximal flex. So this is why we need to do one more optimizing side branch stand using another non-compliant balloon. So according to the study I was studying. So you can see after optimizing side stand, so the oxygen flex stand was expanded very, very good. So after standing flex, we usually keep the wire inside the branch and use another 3.5 by 12 a non-compliant balloon to do further kissing balloon inflation. So what should be kept in mind is that the balloon size is the undersized for left man. So here, I show I was fighting immediately after the first balloon quash. You can see the gap between two layers of straw is pretty large. So it means that we need to do a further balloon quash using a 4 by 12 non-compliant balloon to completely quash the side stand, as I showed in the spider view. Immediately after the balloon quash, you need to rewire the side branch. So, because we kept the flex wire in the position. So we use the third wire according to the map of the previous wire in flex to rewire from the proximal cell. So this is very important because the flex stand has been quashed much more. So actually, the proximal cell is pretty small and irregular. So usually we can rewire from the proximal to middle cell. But the key point is that to avoid to rewire from the distal cell, because of the balloon quash, there is a gap between side stand with the carina. So immediately after successful rewire into some flex, we need to do further kissing balloon inflation. So the left one is a right kissing balloon inflation. On the right two figures, I provide how ugly of the kissing inflation. So in general, the kissing two balloons should be overlapping as short as possible in the left man to recreate the metal carina. So after kissing balloon inflation, we use the long stem from right to fully cover the ostium of left man. Immediately after standing RID to left man, we use the full non-compliant balloon to post-dilate. This is the second part to make sure the full expansion of left man stand. So after second part, we need to rewire some flex again. Personally, I prefer to use the BMW wire to rewire some flex. And also from the left epicaudal image, you can see, you can clearly see if the some flex wire access to some flex from the proximal or middle cell. Once it is successfully into the flash, we need to do a second kissing bone inflation. So for kissing bone inflation, usually we recommend to do sequential inflection study from third branch. So usually we need to inflate the third branch balloon by a minimal 16 atmosphere. After that, we need to do simultaneous kissing inflection with very short overlapping of two stand in the left main. For this case, we use a 3.0 in Sunflex, another 3.5 in RAD. So after final kissing inflation, so final part was performed successfully. These are final angiography from epicaudal cranial and also from spider view. After this decal quality technique for this case, we measured the invasive FFR for distal sunflex. It was greater than 0.80, so we did not touch the distal lesion in sunflex at all. So finally, we rechecked the eye was studied from RAD to left main on the left side and from sunflex to left main on the right side. So both then in RAD and sunflex are fully expanded without significant prolapse of plaque, no thrombosis formation, and also the ostial left main was fully covered by RAD to left main stent. So finally, there are several key points of decal quality stenting technique. A short protrusion of sunflex stent into the left main, balloon quash using an appropriate size according to the left main diameter, rewire into sunflex usually from proximal cell. For some cases, we can rewire from middle cell. Alternative inflation before each kissing inflation. First kissing followed by rewire to the standing RID to left main. After that, rewire again into the third branch alternative inflation followed by second kissing bone inflation and the port technique. Thank you very much.
Well, that was an extremely elegant example of the DK crush, and it was a phenomenal result. Before we go to the audience question, your protrusion is pretty minimal. How do you define that versus the nano DK crush? Are we considering now we're trying to achieve a nano crush, or is 1 to 2 millimeters? What is your approach?
Yeah, actually, nano crush is a good stenting technique too. But personally, I think if the protrusion is too short, nobody can make sure the full coverage of ostial sunflex. Secondly, that we always recommend to rewire from different cell. So if nano crush uses for some case, it could be transferred to classic crush. Thank you.
Okay, great. And I like the fact you're adding more steps to the 12-step DK crush, but I believe that optimization of the ostial circumflex is key. And one way to do it is adding that step with the NC balloon before the crush. But I do think prior to stenting, making sure you have optimal plaque modification and good vessel prep is another way to assure your ostial circumflex is going to have a good luminal diameter or area. I think that's something we underestimate, and it is frequently underexpanded. So I like adding that extra step, even if you have good vessel prep. So I'll go.
Charlie, I have one question that was asked to me. The second time you recross, was it important to recross in the proximal or middle cells rather than any cell? Why do you think the second time when you recross, why should it be proximal or mid? I mean, is there science behind that? Because you've already done that once before, but the first proximal recross. But the second time around, is that essential?
Yes, thanks for your good question. Actually, for second rewiring, because we have performed kissing bone inflation, usually we can rewire even from distal cell. But a different stent has different design. For example, if a stent has very large cell, so it's still there is a risk to rewire if below the side stent. Also, I wanted to answer a question by Don Abo. Actually, even I have showed 12 staples, but I think for very skilled intervention cardiologists, there are only 5 staples for decal crash. Very simple.
Yes, you make it look simple for everybody. Terrific. Okay, go ahead.
Valerie has a question.
Yeah, to Sauliang, about the angle of the bifurcation, do you think that there are some angles where the decay crash is mandatory? Let's say that really can be the best technique, or do you think there are some other bifurcation angles where decay crash is not really the best and we should go for something else?
Well, thank you very much. Actually, for angulate bifurcation lesion, I do believe decay crash is the best stenting technique. Let me give you 2 examples. One is from our decay crash 5 study, because we compare the decay crash with provisional for this left main true bifurcation lesion. But the reason for why there is a high rate of stents on both sides of the provisional stenting technique, and that's because of the stenting main vessel, because very angulated this left main, rewire successful, but balloon or even stent could not be put into the side branch to get the dissection, something like that. So this is the first example. From our definition 2 study, we do for that trial, we only included complex coronary bifurcation lesion defined by definition criteria. All patients are really have the complex bifurcation lesion. So for some cases, similarly, we could not deliver this second stent into the third branch after provision. Thank you.
Maybe one last thing, Giannis, with all your computational modeling, what do you think that angle is the optimal angle, where the narrow angle where you should go to something else, whether it's a DK culotte or when should you avoid a TN protrusion, or what angle is too narrow and
yeah. That's a very good point. And actually, there was a question I tried to answer. When it's like T, the perfect 90 degrees, 80, 90 degrees, or even more than 90, I think the scenario of a T technique is probably the best. I'm not quite sure that the culotte will work well. Culotte is meant for bifurcations in the range of less than 60 degrees, like not T-like. And second condition for culotte, both the distal main vessel and the side branch should be equally sized within 1 millimeter to the proximal main vessel. So as long as we have a wide bifurcation with equally sized branches to the main vessel, I think culotte becomes ideal. Anything out of this, we can consider T and protrusion, or if it's the ideal scenario of 90 degrees, then a T technique. For decay crash, obviously we have the Pope of the technique here, but I'm not quite sure for a T-like bifurcation, the decay crash would work very well because it requires lots of protrusion of the stent into the main vessel to crash it. I think in a nutshell, when it's T-like, a T technique, when it's Y-like, culotte technique, and then T and protrusion essentially can play in between.
And for your case that you presented, because that's not a normal approach that we're doing every day, inverted versus non-inverted, how did you choose to stent the circ first? Is that based on the severity of disease or the angulation?
Yeah, so the scenario is that once you define the complexity based on the length of disease into the side branch, as we discussed, with 10 millimeters being the threshold, once you decide about the complexity and you decide about two-stent technique, then the next question you have to answer is which vessel I stent first, the side branch or the main vessel. And the answer to this question comes from what is the likelihood of losing or jeopardizing the ability to rewire the side branch after I fix the main vessel. So if we feel that it's a very calcified, very angulated, very tough side branch takeoff, and we have high chances to lose the side branch or compromise it after we stand the main vessel, then the best approach is to stand the side branch first. In this case, either you stand with a DK crash or you stand with any inverted T, inverted top, inverted DK culotte, which is inverted means I stand the side branch first. And whether you do T inverted T or T inverted top or inverted culotte, it's dependent on the angulation. If it's Y-like, inverted DK culotte will be perfect. If it's T-like, inverted T would be perfect. And again, inverted top is anything in between.
Perfect. Maybe we can move now to some questions from the audience. We've got 10 minutes left, which is a good amount of time.
I think Charlene wanted to make a comment.
Oh, yes. Yes.
I'm sorry. I
Yes.
have two more comments about the DA culotte and the T-stand technique. Basically, a culotte stand technique is similar to T-stand technique. Secondly, I think because there is a high rate of resistance losses at the osseous side branch, so for reverse T technique, I think the patient will be at high risk for ischemia during follow-up because already was treated as a side branch. Third one, I'm also the founder of DK culotte landing technique. After that, I modified to mini DK culotte landing technique. But personally, I don't recommend the culotte landing technique for left main bifurcation because from our DK practice 3 study, during 3 to 5 years of follow-up, there was a very high resistance on both sides after culotte landing technique. This is a typical drawbacks of culotte landing technique. Thank you.
All right. Terrific. Well, maybe we'll definitely need a debate another day on this topic. But anyway, let's move to the questions.
But we have a consensus to some extent here. You know,
Yeah.
I don't think for the angulations of left main, which are usually 70 degrees plus, DK culotte is the best approach.
Yeah.
For left main.
Terrific. John, are you going to bring some questions in from the audience?
Yeah, I have a few, some of which were kind of recurring from the last bifurcation club as well. So I'll put those out there again because there's a lot of interest. And this is a practical question. I think, Dr. Chen, for your case, you showed 2 BMW wires throughout the case. What are the panel's kind of standard algorithm of wire choices in terms of class of wires and then wire for side branch access after jailing it?
Well, I use 2 workhorse wires, non-hydrophilic workhorse wires. Generally, I just choose 2 of different colors so I can tell them apart. So I may use something like a run through and a Monamo. But however, you can use the same one if you want. I don't tend to go to hydrophilic wires unless there's an issue crossing, either initially or afterwards. And I always, anything polymer coated, I would remove as soon as I've accomplished the task at hand with that. I don't tend to work with them. And so it's amazing how infrequently you need to escalate to a more aggressive wire in these bifurcations. Most of the time, workhorse is fine. Anyway, it's certainly an option. You can go to a hydrophilic non-polymer coated first, and if needed, a polymer coated wire. I'd be interested to see what others are doing.
Totally agree.
Anyone else have a different strategy or?
Valeria, what do you do in the Netherlands?
Yeah, I think what's important, indeed, I usually start with workhorse. It's important to have a wire which can really keep a good shape of the tip, because then you can, try multiple attempts to rewire the side branch, and you will anyhow have the support of a good shape of the tip. That's I think my preference.
Charlene, are you still with the BMW or do you change out? He taught me how to do it many years ago, like a decade ago, using BMW wires. I was so scared of it. doing it, but anyway, still using the BMW, or do you change? Okay, all right.
How about you,
this-
Javier? What are you doing?
Me, I use a run through and a BMW that I alternate. What you need to know is that if you do good proximal stent optimization with side branch and do a good pot, your wire will always go through. You know, that's what I've learned. Good PSO, good pot. There's no reason why a wire would not go back.
And I think if you're stuck on that point, which is the rewiring aspect, then doing another pot. And the EBC has a really remarkable document that's a troubleshooting document that will take you through the bifurcation algorithm. And at any step you're getting stuck, it will tell you the possible reasons, 3 or 4 reasons why, and give you potential solutions. So that is a really important document to keep in mind, because in general, again, you want to just go back and make sure you've done the proximal optimization and then try to recross.
So that is a recurring question we get on these chats is if you've done proximal optimization, you're still struggling, what is some tips and tricks you could share with the attendees on how to rewire that difficult side branch?
Yeah, I think other than reshaping your wires, there are angled catheters like the Supercross. If you're talking about a proximal bifurcation like the left main, often dual lumen catheters like a twin pass or a Suzuki will allow you to, change where where your wire is probing the ostial side branch. So those are some suggestions other than escalating to a polymer jacketed wire or changing the curve is, having some other supportive device like a microcatheter. I mean, Giannis, you were working on that troubleshooting document. Do you have any other suggestions?
Yeah, I think that to put in some kind of like stepwise approach, one is you take your main vessel wire and try to go from distal struts into the side branch. You cannot do it. Then obviously you have to escalate wire at this point. And then if this does not work, you can consider using a dual lumen catheter. If this does not work, then I guess another pot, more aggressive pot to open up more the struts and relocate the struts, and then repeat the same from again from the beginning. Try with a polymer jacketed wire and with the dual lumen catheter again, or the integrated catheter. I believe with a good wire, at the end of the day, with a good support from a dual lumen or an integrated catheter, it's very unlikely not to make it. It'll be a really rare case that you cannot rewire at all.
Yeah, and the cases I've seen that happen, it's people who've kind of had an extensive crush, like a very long overlap, or that there was inadequate expansion of the ostial side branch such that, there's risk of getting behind those struts. So I think, again, if you optimize the side branch stent before it is crushed, you'll have less likely to have that issue. Yeah. We probably have time for one last question before we wrap up.
Thank you.
Oh, I'm
sorry.
sorry.
No, go ahead.
Yeah, one more comment about the kissing balloon inflation. I think the quality of kissing is very important. So why I always say, so overlapping or two stent in the main vessel should be as short as possible. We do have serial intravascular image study to confirm short overlapping is very, very important. Thank you.
Well, Shawnee, I have one question to ask you. Now that Valerie and all have come out with this imaging of the side branch, do you think, and you did an imaging DK study, do you think that will increase or change the way we think about side branches and adding that to lesion complexity? If imaging is now included, we didn't use that in your definition study. So what do you think now? Will you image more to include them in the trials?
Yeah, very good question. Intravascular image is critical for left main, also left main African lesion. In our definition 2 trial, so I was only used in 40% of the patient, but for left main, definitely 100% in my cath lab. Now one decaquation trial is ongoing to compare IVOS-Gadi and angio-Gadi decaquation technique. So far, only 60% of patients enrolled. Many interesting findings from the IVOS-Gadi group. Thank you.
Terrific. Well, maybe as we wrap up here, we can just go down the panel for your last final, recommendation for getting an excellent outcome with left main bifurcation stenting. So maybe we'll start with Dr. Paradiez. What's your recommendation?
Well, my recommendation, and it was a terrific session. So a lot of take-home messages, but my recommendation is always to carefully plan the procedure up front and be ready for any dynamic changes of the bifurcation and use imaging.
Terrific. Giannis?
Yes, so 3 words: planning, and 2 more on top of those 3, imaging, and follow the steps religiously. I think this is the most highly technical field. Once you are cheap and you try to bypass a step, you might end into a big trouble. So follow the steps religiously, meticulously. You need to be OCD.
Okay, Xiaoying.
Okay. I feel a few words cannot say everything. I think a very carefully assessment of angiography and pre-procedure intravascular imaging are very important. Secondly, I think the left mass study is very important, and also we need a very wonderful skills. Thank you.
Okay, and Tanvir, any last words?
Well, I think everybody said what was on my mind, but I think it's very important that there are no shortcuts. When Xiaoling taught me DK Crush about 10 years ago or so in Nanjing, I followed every step religiously, actually, and you'll get in trouble if you miss that one casing, or if you don't do proper part. If you don't do things correctly, you'll get into a mess. And the implication for the patient is that this is the left main. If it thromboses or something bad happens, the patient's going to die, And, you really have to do this very, very meticulously.
Okay, so in conclusion, the stakes are high, but I think certainly everyone here on the panel has confidence in those attending the webinar that this is certainly a lesion subset you can tackle with the right tools and experience. And we really appreciate you participating tonight to learn more about it. And thanks, SCAI, and thank Medtronic for hosting this webinar tonight. Hope you have a good evening.
Thank you. Good night.
Thank you, everybody. Bye.
Thank you. Good morning.
Good morning.
Good morning, good evening, and good night.
From all over the world.